Good morning. My name is Shadi Al-Salibi. I'm a pediatric infectious disease specialist at Mass General Hospital for Children in Boston. I've been asked to talk to you today about some of the interesting cases that I have seen during the many years that I've been practicing infectious diseases. So, all of these are real cases, and I will try to just make sure these cases are actually common things that you would see in your practice. Now, some of these cases actually, I put a severe sort of spectrum of the illness to say, just to make sure, the point comes across and you have like a pictorial demonstration in front of you, just to make sure you keep remembering some of the stuff that I'll be mentioning. So without further ado, we should get started. I have no conflict of interest when it comes to this particular presentation. Again, this is about recognition of infectious diseases features, problems that you might encounter in your practice. I'm going to try to accomplish this using clinical and radiographic pictures. I'm going to do 5 cases in total, and I thought, this can give you like a good sort of overall general ideas what pediatric infectious diseases is like, and hopefully through in each and every case we can try to sort out, a few points that you can sort of, leave home with. I also have sprinkled in there, throughout these cases, a few multiple choice questions. I'm going to pause when I ask these questions just to let you gather your thoughts a little bit. And then after that, we can, carry on and hopefully you can, verify your answer and try to figure out, again, some thoughts and some, take-home messages for you to keep. So this is case number 1. And case number 1 is a 16-month-old with a rash. And this child I heard about after being admitted to the inpatient hospital floor with a diffuse rash. He came in for further management. This child is fully healthy prior to the onset of this illness, no major health concerns, fully vaccinated. And this present illness seems to have started 9 days prior to admission to the hospital. He had visited his pediatrician that day. He was irritable. He had a bit of fevers, and then his pediatrician diagnosed acute otitis media, and he was started off with amoxicillin therapy. Mom reports that, right after starting the antibiotics, the day after, he had rapid resolution of the fevers, and his symptoms also revolved, the ear tugging. He had a bit of runny nose, if I recall correctly, and that seems to subside a little bit. 7 days into the illness, so 2 days prior to his admission, his fevers came back, and this time Mom records even higher temperatures, up to 102.5. She also said that, he started developing this rash, mainly in the trunk, but then also creeping up over the next day or so to his extremities, both upper and lower extremities, his neck, cheeks, and his face. So she made another visit with him to his pediatrician. The amoxicillin was stopped and azithromycin was started to complete a 10-day course. At the time, I think he was like 7 days into his course, so for 3 more days the pediatrician has suggested. He came to see us in the emergency room because his fevers have continued high grade. His rash had become more confluent, has been persistent, and now he started having some loose stools, and his PO intake has significantly declined. He remained stable, but Mom was concerned enough to bring him to the emergency room. I'm going to try not to describe this picture to you, probably give you 5 seconds or 10 seconds here to sort through your thoughts here, paying specific attention to the way the picture, the rash is presenting, the extent of it, and perhaps, peeking into his eyes and behind that very cute binky up there that you can see. So 10 seconds there. All right. So let's try to sort out these, the rash that we have, and I, kept a small picture right up there to refresh your memories there. So what would your most likely diagnosis be? I've seen him in the emergency room that day, and let's see. Do you think this is a viral exanthem like enterovirus? B, is this a skin manifestation of a bacterial sepsis? Is this patient bacteremic, and what you see on his skin is a manifestation of that process? C, is this a drug reaction with erythema multiforme? D, is this Stevens-Johnson syndrome? And E, you are unable to tell. You have just too little data to work with. All right, so as we try to sort out through the many different possibilities that I've outlined for you, probably going to, show you a few more pictures of this young child. So maybe I can start by describing these to you guys. You can actually see these very sort of prominent lesions that are fairly diffuse, right? The way that these lesions would start like a small macule here that would sort of progress into like a circular kind of lesion moving outwards with very clear-cut and sometimes raised borders like that. And, as it becomes larger in circumference, you can see the middle of it sort of clearing out. The clear description of it is a target lesion. So again, starting out, as a macular, a small rash right here, and then a mature one would look like something like this. And as these, target lesions become larger, they sort of coalesce and, become more confluent here. Now, let's move back. So if you can look at his back here, this is a picture of his back. This is his diaper down here. So his back is like fully covered, and you can see all these sort of singular rashes coalescing into like one large rash. The middle becomes a little bit sort of grayish here as the rash matures. I also wanted to show you a picture of his eyes here because that will become also important. Picture of his lips. You can see like his lips and his nose totally not affected by this rash, and this is important in a way that will be shown to you in just in a few slides here. And his eyes are totally clear. You can see no conjunctival injection here whatsoever, no discharge, no conjunctivitis, no conjunctival swelling. This is super important. So what do I think it is? I think this rash is most consistent with erythema multiforme. And when you think about erythema multiforme, you should think about these rashes that are for the most part drug-induced or a side effect of an antimicrobial, but also other biochemical agents. So there's a continuum when we think about the erythema multiforme, and the continuum basically starts with erythema multiforme. It progresses to Stevens-Johnson syndrome, and the other spectrum of that continuum is what we call Lyell syndrome, toxic epidermal necrolysis. And, the differentiation, I think, is fairly arbitrary, but if you think about it, it's a bit based on two specific clinical criteria. The first criteria is going to be the area of the skin involved, i.e., how much of the skin itself is detached. We'll talk about detachment in a second. And also if the mucous membranes are involved or not in the process itself. And the second criteria, trying to differentiate the spectrum of this continuum, if there's any presence, whether there are or not systemic symptoms. So for erythema multiforme, you see these, typical or perhaps atypical target or targetoid lesions. These patients have their eyes and mucous membranes typically spared. So there's no involvement of the eyes. There are no involvement of the mucous membranes. These kids can show detachment, meaning the epidermis can start peeling away, and the detachment area, if present, should include less than 10% of the body surface area. Typically, these kids, look non-toxic. They might have fevers, but most often they do not. As the process becomes more severe, we move on into the realm of Stevens-Johnson's, SJS, called for short. These, rashes are somewhat similar to the erythema multiforme, but now we start seeing involvement of the eyes, involvement of the mucous membranes, and usually we can see two or more distinct sites being affected. One thing you should always remember, and how many times do we get phone calls about, a patient of yours getting antibiotics, and the concerned father or mother calls you, oh, my child has a rash. So it's going to be super important for us to remember that, these rashes can be significant. For the most part, they are not. But, the questions that we always ought to ask, how diffuse they are, and if there are any involvement of the eyes and mucous membranes. Think about mucous membranes as being the mouth, the oral cavity, but also genital. So in folks who can tell you if it hurts when they pee, you should ask them about urinary symptoms. They can get urethritis, sometimes even the area around the anus. The rectosigmoid, the end tip of your colon can be affected in that way, and then you can start, sometimes you can start seeing hematochezia and some blood also being passed along with the stools. These kids typically have systemic symptoms. They are still non-toxic, but, they have fevers. They can have, liver involvement. They can also have joint involvement, and these are things we also need to ask about, abdominal pain, ambulation patterns, etc. And the detachment in Stevens-Johnson's is also less than, 10% of the body surface area. So between erythema multiforme and Stevens-Johnson, the distinction is mainly the involvement of the eyes and the mucous membranes, and also the fact that Stevens-Johnson's typically present with systemic symptoms. Now, when you move on to the TEN realm, this is you are into serious illness sort of territory. These kids are usually sick. They have systemic symptoms. Their eyes and other mucous membranes are involved, and basically you start seeing full thickness, epidermal necrolysis, necrosis of an area 20, 30, 40, 50, typically more than 30% of their body surface area. So think about the pictures that I just showed you and compare those, or perhaps let's just finish up and think about, the case, the answer of case number one. Viral exanthems are usually, they don't show with this kind of target/targetoid lesions. This kid is way too healthy for a bacterial sepsis sort of situation, specifically if that process had been ongoing for many days. Stevens-Johnson, the fact that the eyes and the lips are spared sort of reassure you that this is not SJS, and this rash, as you might have guessed by now, is fairly typical of a reaction from erythema multiforme, probably exacerbated by amoxicillin therapy. So again, think about the picture that I showed you and compare it to this picture right here, right now. So this is a patient that I saw just on the hospital next door at the burn center, and then this is the end. This is toxic epidermal necrolysis, and as you folks can see, there is significant involvement of all the skin surfaces that you can see in front of you. There is bullae that are formed, and there is, these significant detachments. This is called like a Nikolsky sign. You would approach this child's chest, you would put your gloved finger on one of these lesions, and even with a gentle pressure and movement of your finger downward or upward or sidewise, you will start seeing a lot of peeling, and then raw dermal tissue would be apparent to you. You can see also involvement of the lips up there on the upper right-hand corner. You can also see the nose and the nasal mucosa also being involved. This child also, unfortunately, was peeing blood as well, and that was quite painful for him. A zoom into his facial structures. Again, you see the mouth, his mouth behind the face mask being involved. Putting tubes in his nose is not helping, but also significant, nasal involvement and mucosal involvement of the nasal and nasopharyngeal structures. His eyes are also involved. In the next pictures, it's going to show this to you in greater detail. So you see like significant conjunctivitis down here with a lot of discharge also that is apparent to you guys. This child was on sulfa drugs, and he was treated for toxoplasmosis, ocular toxoplasmosis, and basically developed toxic epidermal necrolysis so severe that he needed to come to the burn center and be cared there for, I guess his total stay was around a month. So when, you get that phone call, and that phone call, you've already gotten many, and you probably will get some, from a parent with a child with a rash, think about those pictures that I showed you, but also think about the questions that you need to ask, those things that are going to concern you are going to be, data that suggests erythema that is confluent and widespread. If you're going to see, facial involvement, if there is skin necrosis, if there is any blistering there, this is important. And the Nikolsky sign, you can ask, the parent to gently try to rub the blister. If it detaches and bleeds, this is, let's see you in the emergency room. Also, mucosal membranes involvement. Don't forget to ask about peeing and pooping and if this hurts or not. The presence of fever should also concern you. Enlargement of the lymph nodes, so adenopathy, usually diffuse, is something that you would see. Arthralgias and arthritis, I alluded to as well. And once you obtain some lab work, a CBC might show you eosinophilia. So eosinophilia dress syndrome is another thing that we've seen in conjunction with using antibiotics, but also, toxic epidermal necrolysis is usually associated with high absolute eosinophil count. Lymphocytosis is something that you could see, but also abnormal liver function tests. Transaminitis mainly is associated with these systemic, somewhat invasive processes. What are the drugs that are associated with Stevens-Johnson's and TEN? This list is definitely not all inclusive. But these are, on your left-hand side, there is a column that suggests to you what are the medicines that we see most frequently associated with these specific entities. Amoxicillin is down there, and this is probably the number one cause. This is probably one of the most prescribed antibiotics. So just in the sheer volume of prescription will generate, most problems with SJS and TEN. You also see the sulfa drugs up there. Bactrim is another big one. We've been using Bactrim more frequently these days because of the community-acquired MRSA, and this specific antimicrobial agent has emerged as being one of the appropriate, therapies for CA-MRSA. So it's been used more and more frequently. Antiepileptics are notoriously also associated with these particular entities. number of formulations also of nonsteroidals are listed down there. Other antimicrobials are associated with these entities as well. So this concludes my first case. Then let's move on to case number 2. So switching gears a little bit from fevers and rashes to abdominal pain and vomiting, and this is somewhat of a different age group. He is 13 years old. This child was admitted to the medicine service with an acute illness that started a week prior to presentation. At the time, his mother has developed some kind of a gastrointestinal illness, also with vomiting and diarrhea. His mother's illness, promptly resolved, and his did not. His progressed to some bilious vomiting. He started not tolerating anything by mouth, including fluids, and he started to experience some abdominal distension. By the time we got to see him in the hospital, his diarrhea had stopped, and he had not had any bowel movement for that. For these purposes, he had not stooled for the past 2 days before he came in. There are no significant exposures to note. His past medical history is also not significant to this prior illness. He is on no chronic medications at home, and his family history is also non-contributory to this particular illness. So this is his clinical examination and his laboratory evaluation on admission. So he was not febrile. As you can see, he was in pain, but not gigantically so, 3 out of 10. He was tired, but he was not in acute distress, and the rest of his clinical exam is reasonably normal, except for an abdomen that was somewhat distended, somewhat tympanic. I could not say I couldn't say to you that he is, he had peritoneal signs. He did not, and I could not assess a liver or a spleen, being enlarged. He had, the distension was significant enough that this part of the clinical examination was not possible. His laboratory testing, and I've listed here the data that is significant. As you can see, he did have a fair amount of leukocytosis of 19.2. His platelets were a bit increased. His marrow showed also some left shift, as you can see, 80% segmented. And what really sort of concerned me a bit is that his CRP was 146. Different institutions have different cutoffs for abnormal CRPs, and ours, it's less than 8. So I guess regardless of what your institution has to tell you, 106 and 46 is fairly large. ESR is also elevated. The normal for males is between 15 to 20. So an elevated inflammatory markers with the CRP being significantly so. His Chem7 was not abnormal. Maybe his creatinine is a little bit on the elevated side, but he was dehydrated when he showed up. His amylase and lipase were normal. His LDH was normal, and his liver function tests were normal as well. So they did a KUB in the emergency room before they admitted him. They thought they saw multiple dilated loops of small bowel, lots of air fluid levels, as you will see in a second. They didn't see any free air, so that was reassuring. They didn't see also, gas seen distally in the gastrointestinal tract. And, putting all his symptoms together, and after consultation with the surgical service, they thought he might have a post-viral ileus, like a gastroparesis, a functional obstruction of some sort. So that was the provisional diagnosis. They aggressively hydrated him with intravenous fluid. They gave him Zofran. They also placed a nasogastric tube to decompress. And then on day 2, he felt a little bit better. His vomiting has resolved, but he still was not eating during the first part of the day, started drinking a little bit during the second part of the day, and still had not stooled. Now, on the day of hospital 3, that was a very difficult day for him. He had recurrence of his vomiting, and now the nurse tells us, and he did as well, that they could perhaps saw some fecal material as well coming out with his vomit. His abdominal distension, we were carefully doing abdominal girth, and it was certainly increased by many centimeters during day of hospital number 3. We repeated his lab work during that. At that time, his white cell count, as you can see, the admission labs on the right. His most recent day of hospital 3 data are on the left. 17.3 was his white cell count, not increased but not really decreased. His left shift is maintained, and now we're starting to see some bands right there. His CRP, which is 146, is now even more elevated, 155.5. So this is when they called me. They were not too sure what's going on. He still had not had any fevers, and I suggested we go ahead and do a CT scan of the abdomen. So again, I'm going to give you 10 seconds of silence here, so you can go over the sagittal images of his abdominal scan. So these are more images as we move from laterally to the midline, and the picture on the right is probably the one that is sort of most midline that you will get. Hopefully you can see some abnormality there. And this is the question for you. What is your most likely diagnosis? Are you still in agreement with the primary team? Are you still thinking this is post-viral gastroparesis? Are you still thinking it's functional obstruction? Do you think it's peritonitis, and why that would be? Do you think it's an intra-abdominal abscess, and why would he have one, and where is it? Is it necrotizing enterocolitis, or do you think it's ischemic bowel disease? So this is an intra-abdominal abscess, and as you can see down here, it was not a subtle or a small one. Definitely, there are these air fluid levels, and the patient clearly was not standing up; he was lying down. So you can see these sort of horizontal air fluid level, these sort of large enlargement of the small bowel. So these small bowel loops are significantly enlarged, and you see actually this very large abscess, probably the size of a baseball here, the dimensions of which I've listed, 137, so 10 centimeters in one axis, and just probably close to 9 in the other. And it was in a very strategic location, in this one, because it was in the pelvis where there's not a lot of room to move. But his pathology was mainly because, this abscess was actually squishing the rectosigmoid, this part of the distal GI tract, against the sacrum, causing obstruction. And this is why, the kid has, stopped stooling, but also continued to have, these vomiting episodes per se that, included feculent material at the very end. This is not gastroparesis. We were thinking, initially that this was the case, but that CRP is definitely not compatible with a virus that is resolving and a gut that just is not happy because, a virus has just visited it. A CRP of 150 is fairly large, indicating of significant inflammation, and this should be taken seriously. The patient never had any, symptoms or clinical findings suggestive of peritonitis. Yes, he was in pain, and he had basically this distended bowel, distended abdomen, but he never had signs of peritonitis, and I hope I made that clear during my first slide about this case. Does not have necrotizing enterocolitis. Usually with necrotizing enterocolitis, you see, swelling, swelling of the size of your intestines, and we did not see that. And this kid has no reason to have ischemic bowel disease, and this is definitely not compatible with ischemic bowel disease, the picture that I'm seeing and I'm showing you. So his diagnosis now changed from a post-viral gastroparesis to a pelvic abscess with an obstructive ileus. He immediately went to the IR suite when everything got drained, nothing eventually grew, if I recall correctly. And then down the line, after a couple of weeks of antimicrobial therapy, the surgeons went in. They removed his appendix laparoscopically, and then resected a bit of his small bowel around the appendix itself. The pathology of the appendix ended up showing acute and chronic appendicitis. So we think that, this abscess formation was a secondary process from appendicitis. There was no evidence of granuloma. There were no evidence of inflammatory bowel disease, and IBD was something else we were thinking about at the time. Now, this is a nice study now, 5 years old, published in the Scandinavian Journal of Infectious Diseases, and this is a descriptive study, basically detailing community-acquired intra-abdominal infections that were complicated. These are kids who are all hospitalized. And as you can see, 92% of those cases here were some form of a complicated appendicitis, perforated or otherwise. So, you can see abscesses being down here, including, peritonitis, another complication. Right there in the other 10 out of 123, these were different, other things. So when these kids get admitted with an intra-abdominal, bacterial infection, I'm talking here not like a gastroenteritis, a viral process, or maybe a kid admitted for dehydration. These are kids who, for the most part, end up, going to the operating room for one reason or another, or necessitating prolonged antibiotic therapy. Their symptoms is what you may expect: abdominal pain, vomiting, fever. Diarrhea is less of a common problem, so the absence of diarrhea should probably give you some sign that perhaps something is going on, and probably closer and more careful monitoring of that particular patient is needed. Now, moving on to the microbiology of these abscesses, as you might expect, most of these are actually gram-negative rods, perhaps some anaerobes, the inhabitants of your gut, your lower gut. So Escherichia coli, E. coli is the most significant pathogen, existing either singly or in a polymicrobial mixed infection sort of scenario. Mixed infection were more common overall, and again, this is basically a manifestation and explanation how your gut flora is and what your gut flora is doing. And when there is translocation of one pathogen, you may have a translocation of many. So Enterobacteriaceae are up there. Anaerobes are there too. But in a few, you also saw some Staphylococcus aureus, and this will be apparent in a second, but also some Enterococcus and some Streptococci as well. So moving on to the antimicrobial susceptibility, again in that same paper. So your traditional AMP, GENT, and Flagyl should work for the most part, So for the E. coli, you can see 99% of these isolates being sensitive to gentamicin. For the Klebsiella species, gentamicin is a good coverage, and they did recover a few Pseudomonases, and the PSA that they've recovered were sensitive to gentamicin as well. So, your GENT is a staple right there. The ampicillin will cover your Enterococcus, so they did have their Enterococci being all ampicillin sensitive. So these are AMP-sensitive Enterococci, which most of your Enterococcus, thankfully, still are. So AMP, GENT, and Flagyl for your anaerobes. You are bound to miss a few. So for your Staphylococcus, AMP, GENT is probably not going to be sufficient, although gentamicin can cover some of the Staphylococci, but you never should treat Staphylococcus invasive infection with gentamicin alone. So vancomycin in those sicker kids where you are worried about kids who are at higher risk for sort of more exotic infections, like kids who had been hospitalized before, kids with IBD, et cetera, you might want to do a combination of vancomycin, perhaps a cefepime, or a vancomycin and perhaps a meropenem, like a carbapenem. So Amgen flagyl for your mundane, 90% of your cases, and perhaps vancomycin and imipenem or vancomycin and the fourth generation cephalosporin. Fifth generation cephalosporin would be the way to go. And this concludes our case number 2, and we will move on to case number 3. So fever is, again, on the table. So this is a 2-year-old now who shows up with 6 days of fevers. This boy had been also previously in good health, no chronic prior existing conditions. He presented to the emergency room after many visits to his PCP with persistent fevers. So 6 days, perhaps by then 7 days of fevers. And this is the timeline of his illness. 6 days before his presentation, his fever started out of nowhere, mom says, all the way up to 102. No clear focus initially. 2 days later, he was seen in a local emergency room and was noted to have a large left posterior cervical lymph node and perhaps left otitis media. So they thought, okay, good story, fever, lymph nodes, and perhaps some clinical findings. He was started on amoxicillin and sent home. A day later, after 2 or 3 doses of amoxicillin, his fevers continued, and now he started with a rash. His rash is involving his face, his extremities, his chest, and his abdomen. Folks assumed it was an allergic reaction. His pediatrician changed his amoxicillin to cephalosporin. Now, 2 days before he showed up to see us, his fevers have continued, his rash have continued, and he developed some conjunctivitis. His conjunctivitis are described as bilateral. It was non-suppurative. And then mom saw that his tongue was becoming a little bit more red than usual. And she noted a very peculiar finding is that, that morning when she was taking him to that pediatrician's office, she couldn't put his shoes on anymore. His feet were like a little bit swollen, and they would not fit into his shoes any longer. At the PCP's office, I was not quite sure what the thought process was, but they did do a rapid strep, thinking, rash, thinking cervical adenopathy, thinking continued fevers. Could this be group A strep? His rapid strep was negative, and they continued with antibiotics. And then finally, mom was continuing to be concerned, and she showed up to our emergency room. At the time, he had started to vomit a little bit. He started to have diarrhea. The diarrhea had no blood, mucus, or bile, and he started to complain a little bit of abdominal pain. By then, I think he had lost like a pound or 2. He had not been eating much and drinking very little, and mom describes him as being sort of very irritable, very hard to console. His review of system, as you can see, fussy and clingy, no joint swelling, no respiratory symptoms, no peeling of the skin, no rigors, no chills, and he did not have any significant exposures. So this is when I met him in the emergency room. He was febrile at the time, sort of moderate grade fevers up there. He cried during the entirety of the examination. It was difficult to console him. His neck was supple. He was moving it all the way, right and left and up and down. His oral exam was difficult, but, his tongue described as strawberry. I did confirm it myself as well. And he had like a large lymph node measuring probably a couple of centimeters in the posterior triangle on the right. The rest of his clinical examination is normal, except his extremities, where I could confirm with mom and to my own eyes, he had some swelling of the feet and of the hands as well. He had this rash that at the time was not as angry as when it started, but certainly a rash that I could note. It was maculopapular. It was blanching. It was not particularly itchy, and I didn't think it was like infected at the time. There were no target lesions. that I could see on his integument. There were no desquamation as well. So some lab work that were available to me even before I came down to the emergency room and see him. His white cell count is a little bit elevated for his age group. You know, the high upper normal is 17, so he was 21,000. His platelets were upper normal, but still within what we consider normal. Some left shift, but nothing exciting otherwise. His ESR is elevated at 91, and his CRP is 127, again with a normal of less than 8. And on the right is his chemistry profile. You can see a low sodium measurement, a bit of dehydration up there with a maintained creatinine, his albumin a little bit on the low side, and some of his liver markers being elevated. ALT was up to 83 with a normal, upper normal of 55. So some pictures for you here. So clearly irritable, were very hard to take pictures of. You know, he's thrashing about, crying. You cannot very well see his eyes. There was some, you know, red streaking in his conjunctiva. It was not draining. There was no suppuration. It was bilateral. And by the time I examined him, it was not as bad as it had been described. You can see a bit of his rash here on his left arm, some cheek redness as well. And I'm not sure if his extremity swelling is as prominent as it was in real time, but, you know, you're going to have to trust me on that. You know, his toes were like, you know, sausagey looking, and, you know, his whole sole, you know, there's no arch to it. It was like just flat and swollen. So what next steps would you suggest? So this is a child who's coming to your emergency room or to your clinic. So what would you suggest be done next? A, the symptoms are suggestive of a systemic drug reaction. Discontinue the antibiotics and then send home after adequate hydration. Make sure he's drinking. B, the rash, cervical adenopathy, and high fevers may indicate group A strep, tonsillopharyngitis. Give him a dose of ceftriaxone and then follow the next day. C, this is clearly a viral gastrointestinal illness. Now the kid is vomiting, he's having diarrhea. So admit to the hospital if a PO challenge in the emergency room is not successful. And finally, D, this child needs admission to the hospital for administration of a blood-related product. So hopefully you guessed what this entity is. This is clear Kawasaki disease, you know. This is probably, you know, they usually come textbooks, but not often. This kid was a textbook KD patient. So there is no blood test, as you know, to diagnose Kawasaki disease. Dr. Kawasaki in Japan in the 1950s and 1960s put together this constellation of, you know, clinical signs and symptoms together as being diagnostic criteria for this particular entity. We're not too sure what the underlying process in Kawasaki disease, or rather the underlying entity in Kawasaki disease is. There have been many suggestions throughout the decades, most recently coronavirus a few years back. We think it is a virus of some sort, just from the epidemiology of Kawasaki disease, but we do not have a name to that virus yet. So what are the diagnostic criteria for Kawasaki disease? You have to have fevers for 4 or 5 days or more, and then you have to have 4 or 5 out of the following. So conjunctival injection without exudates, sometimes with, most of the time, rather limbic sparing. Oropharyngeal changes, as this kid clearly had a strawberry tongue, is one description we use for, you know, a beefy sort of red tongue with prominent papillae that we see commonly in Kawasaki disease. And as you move from the eyes and the mouth into the neck, you can sometimes feel lymph nodes. For this criteria, for you to check this criteria, you will need one of these lymph nodes to be larger than the others, or maybe a single unilateral lymph node. This this node needs to be 1.5 centimeter or larger. This is probably one of the least present criteria. I see it somewhat rarely in Kawasaki disease. This kid did have it. So having other smaller lymph nodes does not strike this one out. So if you see one, that's good enough. Changes in the extremities, like I told you, specifically enlargement. Sometimes I've seen dryness of the extremities, maybe some red hands and palms and soles, and this rash that is usually polymorphous. There's not one typical characteristic rash in Kawasaki disease. They can come in any different ways, shapes, or forms. The one thing that I would want to highlight for you folks about Kawasaki disease and these criteria is that these criteria do not have to be present altogether in one specific instance in time. So if you don't see red eyes, it's important in your clinic or in the emergency room, you have to ask about a history of red eye during this, this present illness. This is day 7 of fevers. Did he have red eyes the day before yesterday or 4 days ago? So you have to run this list specifically and carefully with the family to try to make up your mind if they do meet diagnostic criteria or not. Now, if there are coronary abnormalities, and this is the number one worry about Kawasaki disease, and this is why we treat Kawasaki disease, to try to blunt the occurrence of coronary abnormalities. If you do have that, and 3 out of 5 criteria, I think that's probably good enough. In my book, probably 2 out of 5 is good enough too. This is the differential diagnosis of Kawasaki disease. I'm not going to run into all the details here, but a paper that I refer to all the time is by Neuberger et al. It's a paper in Pediatrics from 2004. Dr. Jane Neuberger is a cardiologist out of Children's Hospital in Boston, and basically she has co-written the recommendations from the AAP about therapies and long-term follow-up, including in the acute phase and in the convalescent phase, with major emphasis on cardiac care as well. So this is a paper that you should keep tucked away and refer to as needed. Now, Kawasaki disease is a vasculitis of the middle-sized vessels. So middle-sized vessels exist like everywhere in our body, right? So you can see a constellation, a multitude of symptoms. We will not go into all of this, but basically this list is inclusive, and you will find this list in the paper that I mentioned. Laboratory findings will include your elevated ESR, your elevated CRP, your hyponatremia, which this kid had this one, this kid had this one. We typically get a bagged urine just looking for sterile pyuria. Elevated transaminases is something else we look for and is frequently present in CSF. Hopefully these kids will not need an LP, but in case they do get one, it's not uncommon to see pleocytosis in an ALT, in the CSF or in joint fluid, etc. We do treat Kawasaki disease. All patients need to come to the hospital and get treated, not because we care too much about their fever, and we want to make sure their cardiac health is maintained. So again, moderately sized vessels are affected with aggressive inflammation, and the heart vessels are no exceptions. So in this way, treatment is efficacious. Untreated, the incidence of cardiac pathology in Kawasaki disease is probably as high as 20 or 30%, and with high-dose IVIG, the incidence of cardiac ectasias and aneurysms decreases to less than 5%. So it's important for us to recognize these kids as soon as possible and get them therapy as soon as possible. Aspirin is a historical medicine that we use in these particular instances. Initially, we use high dose just because people used it initially as high dose. It has antipyretic properties, but also antiplatelet properties. So as the fevers dissipate after IG infusion, the aspirin dose, basically we we decrease it to the antiplatelet dose of baby aspirin, usually for most patients, 3 to 5 milligrams per kilo per day. And I've listed here some subsequent care after IVIG infusion and while you are on aspirin therapy. So this kid should not go home. This kid, the role of antibiotics is, is very debatable in this case. This kid needs to be admitted to the hospital and get IVIG. One of my colleagues, this is another patient. Thankfully, the patient that I just presented with pictures basically did not have any cardiac findings, did not have any cardiac anomalies, but this kid here that I'm presenting to you right now was not as lucky. He did come in, I think, 10 or 11 days into his symptoms, and by the time we echoed him, there were significant cardiac pathologies. These are the cardiac vessels right there, the RCA on the right. The heart is resting on the side and the apex. So on one side, you see an RCA descending from the right side. The left main goes out on the left side of the aorta, and it basically bifurcates here into a circumflex that goes around the heart, and the LAD that goes ventrally all the way to the apex. Here you can see this over here is the aorta, and then from the aorta you see the left main stem. So the caliber of the circumflex is like a couple of millimeters at the most, and you see this sort of large space here, and this is like a saccular, unfortunately, aneurysm at the level of the circumflex and the bifurcation. This kid also had pathology on the right RCA. So this is again the aorta, and this is just above the right coronary cusp, where the takeoff of the right coronary artery is. Again, the caliber should be tiny, and you see like enlargement at the base with a saccular aneurysmal dilatation right here. And I think the measurement of that particular aneurysm was around 4 millimeters. So this is the kind of pathology you do not want to end up with. And this is why, aggressive early therapy is recommended in Kawasaki disease. Moving on to case number 4, this is a sick child at the burn unit. And I'm going to show you a few pictures when I met this child literally 36 hours after the onset of this illness. The kid had been healthy prior. He had a G-tube because of I think he was autistic at baseline, and was not too good, with oral intake. So a G-tube was inserted at the age of 5, a couple of years before his present pathology showed up for enteral feeding. Now, the present problem started a day prior to admission, and then just 36 hours later, he is in the ICU in the burn unit. And this is his picture. So I'm going to, again, give you 5 seconds here, just walk through this picture a little bit. This kid was in the intensive care unit. You can see he is intubated. He also had problems maintaining his blood pressures, and he had some evidence, both clinical and biochemical evidence, of end organ failure and damage with poor urine output and significant respiratory problems. His lung picture was suggestive of ARDS. So a few seconds for you folks. So what do you think this is? What do you think this pathology is? You can see the G-tube is like right up here. You can also see this is his umbilicus down here. And if you look closely, you can start seeing not only his subcutaneous structures, but you can see a little bit of the musculature of his anterior abdominal wall. So and you can see fairly demarcated lesions over here. So like it looks like the scalpel of a surgeon, right? So demarcated lesion. Why that is, you think? You think this child has myositis, viral myositis, like we see sometimes frequently with influenza? Does he have invasive group A strep infection? Does he have aggressive MRSA cellulitis needing surgical intervention? Is this an intra-abdominal infection with a perforated viscus of some sort? and the surgeons were consulted, so we might as well ask them, what do you guys think? So this is unfortunately a very significant and problematic case of necrotizing fasciitis. I get a lot of phone calls from concerned physicians about, is this cellulitis that I'm seeing, necrotizing fasciitis? There are some questions that I always ask. And so the progression is always something that gets highlighted to me. It started as a pimple on his forearm, and now it's involving, the whole site, and now it's like 10 centimeters in diameter, and it's been a couple of days. Should I worry? I don't think the rapidity, the rapidity of, the progression of symptoms is important to note, but I think what is most important, because necrotizing fasciitis is basically the fascia being aggressively attacked by group A strep. And the fascia itself is, as you know, subcutaneously, it does involve nerves and nerve endings. So one common feature that we see in necrotizing fasciitis is pain that is disproportionate, like out of proportion of the redness that we see. Sometimes, the redness would have a diameter of 2, 3, 4, 5 centimeters, and the pain would basically outstretch the markings of the edge of the erythema, and the edge would be a diameter of 10 centimeters or so. So think about pain in areas where you don't see pathology with your eyes. Think about violaceous discoloration of the skin, another question you might want to ask your patient over the phone or a resident calling you from the emergency room. Think about bullae and blistering. Blistering is another thing that we see in necrotizing fasciitis, and not specifically with group A strep, but with other, gangrenous, probably clostridial infections. You can actually feel subcutaneous air. You can hear crepitus. These infections are not subtle. These infections are aggressive, and they are severe, and these kids are not only in the hospital, but typically in the intensive care setting. They have high-grade fevers, they are tachycardic, they are hypotensive at times, and exhibit exhibit end organ failures. This is a table from UpToDate, detailing some of the, flavors of infections that involve, muscles and fascia. We will not go into details because we are running out of time, but this is a good table to refer to. So now that you've diagnosed group A strep infection, what do you think is not correct of all these statements? So not correct. A, necrotizing fasciitis and other invasive group A strep infections in children can occur as complications of varicella. B, the portal of entry of invasive group A strep infection often is the skin, but is not recognized at times. Invasive group A strep infections can be severe and can be associated with streptococcal toxic shock syndrome. D, finally, treatment of group A strep necrotizing fasciitis consists of aggressive and prompt antimicrobial therapies. While surgery is usually not indicated, IVIG may be considered in certain situations. So which one do you guys think is not correct? Important to remember that necrotizing fasciitis is a deadly infection. It's an infection, if you treat with antibiotic alone, where the mortality is 100%. So antibiotics are not curative alone in this situation. Antibiotics are a large part of the therapy, but I think what is equally or perhaps even more important is aggressive debridement. So surgery, the surgical folks needs to be involved in all cases with suspected or proven necrotizing fasciitis. These guys will need to be aggressive, debriding all infected tissues with demonstration of healthy margins. So they sometimes overdo it, as they should, because this infection can be very aggressive and is deadly if not treated promptly and correctly. Sometimes repeat resections are indicated for devitalized tissues. The antibiotics should be applied at maximal dosages please have infectious diseases involved as soon as possible. Usually it's a combination of a bactericidal agent, a cell wall inhibitor, but also clindamycin is a staple as well. Clindamycin is bacteriostatic, but basically it prevents the assembly of bacterial ribosome, hence, stopping the toxin production, stopping the enzyme production by way of stopping protein synthesis. So clindamycin is in there, as well as IVIG could be used in folks with problems, with ongoing problems. Again, ICU care is paramount with appropriate fluid resuscitation and otherwise. So all the statements A, B, and C are correct for Group A strep there. Statement number D is incorrect. So surgery is indicated for all of these patients without exception. So let's move on to our last case here, and this is a case about a pneumonia that is not improving on therapy. So this is a 3-year-old female who was admitted to the hospital for pneumonia. That pneumonia was detected by her pediatrician after an illness on an X-ray, after an illness that was ongoing for about 7 days or so. The patient showed up with high-grade fevers, cough, intermittent abdominal pain. She was seen multiple times during these 7 days, and then she was placed on amoxicillin. Her past medical history shows no serious illnesses, no recurrent infections, no prior hospitalization, fully vaccinated, not sure at the time if she had received PCV7. At the time of the PCV7, she lives with her parents, no sick contacts of note, and then other than poor appetite and decreased activity, she really had no other symptoms to report. Her CBC was very elevated, showed very elevated leukocytosis, 24.9, white cell count, a bit of a left shift and some bandemia as well, 8 bands, and the blood culture was taken at that time, and that was pending. Her clinical examination at the time of admission was 101, so febrile, and her lungs were noted for decreased air entry over the left chest. So mid-area and the base were actually fairly silent, with no air movement noted. There were some subcostal retractions, but no significant respiratory distress and no abdominal breathing as well. So the child was admitted to the hospital. From the emergency room, she was started on intravenous vancomycin and intravenous ceftriaxone, but remained febrile 3 days into her hospitalization. Her clinical examination was not getting better. It's been 3 days now, so what is your most appropriate next step? A, if the patient remains stable, watchful waiting is acceptable. The antibiotics need time to work. B, this is most likely a resistant organism, and antibiotic coverage should be expanded. C, ensure therapeutic dosing of vancomycin with serum level testing. D, imaging is appropriate at this juncture to assess for progression of the infection. So let's go over through the four choices I've given you out there. So the kid has been admitted to the hospital, had been on vancomycin and ceftriaxone, so fairly well covered for potential lung pneumonia pathogens, and not getting better. And his aeration or her aeration was getting worse. So, I think we've waited long enough. 3 days on antibiotics is plenty to see some kind of improvement. So watchful waiting, I don't think is acceptable at this time. Resistant organisms should always be in your thought processes. But this is a kid who's healthy at baseline, no recent or prior hospitalization. So why would she have a resistant organism, and what that resistant organism would be? So I think this is probably not an acceptable answer. Now, therapeutic dosing of vancomycin should always be ensured, and hopefully by day 3 you've had vancomycin at appropriate dosing yet. But still, vancomycin and ceftriaxone in combination should have affected some clinical changes by day number 3. So at this point in time, I suggested imaging. And our go-to imaging initially used to be a CT scan. Everybody used to get irradiated with CT scans and contrast, et cetera, et cetera. If you had, issues with your kidneys, contrast become a problem. But now and recently, probably over the last 5 years or so, our go-to modality is an ultrasound. The operator of the ultrasound needs to be trained in these techniques. It's very much operator dependent, specifically for those effusions who are smaller, and if you are looking for loculations and things. So as you can see here, black is air, so or fluid. So you can see here fluid between the chest wall and the base of the lung here, and not only you can see fluids, but you can see some septations here. So this is a maturing effusion, probably by now an empyema, and that's all you need to know. Sometimes the surgeons, if they want to go in there, and we'll talk about the appropriateness of that or not, they might ask you for a CT scan. This kid ended up having a CT scan, but sort of nothing additional or exciting sort of showed up. That process on the right lung is very obvious there. So for slow to resolve bacterial pneumonias, consider how your antibiotics are delivered, the dose of your antibiotics, and basically the compliance with your antibiotics. Look for collections, pneumonic, intraparenchymal, like abscesses inside the lung parenchyma is another thing you should think about. This is not as amenable to ultrasound as a pneumonic effusion, so the ultrasound discussion becomes much less suitable in that particular disease process. Look for alternate microbiology, and also be patient. I think 24 to 48 hours is a reasonable time frame for your antibiotics to start working. Carrie Byington, I believe from Utah, had been working with pneumonias for some time now. She's also been assessing the impact of pneumococcal vaccination on the epidemiology of invasive pneumococcal diseases, and this is a table from one of her publications in PIDJ in 2007. So these are the stages of pneumonic effusion / empyema. Initially, it's free-flowing, and then it becomes fibrinoprurient as the fluid gets more fibrous and more loculated. And then the stage number 3 is basically the organized stage where there's a fibrinous peel over the lung itself, and the lung becomes entrapped with some process of obstruction. And these are the 3 stages. Now, the management in the past, we used to put like a pigtail in an exudative stage and not worry about it. And then as we move on to more organized stages, most people would do VATS. Where I did fellowship, everyone would use to get VATS procedure. Now we know that VATS is probably not indicated in most patients, in all patients, and I think it only is indicated in only a minority of patients. Maybe when that peel sets itself up, you may need VATS, but I think in all other situations, just putting like a small pigtail or a small chest tube and infusing TPA, fibrinolysis in there. And as you can see, this is a table that summarizes a fibrinolytic intrapleural fibrinolytic therapy in children. Not giant numbers by any chance, by any stretch. These are RCTs here, and as you can see in those two RCTs that compared VATS to intrapleural urokinase or strained TPA, the length of hospital stay is pretty much the same. Think about VATS. How problem is, so it's the OR time, it's also morbidity, it's also pain and pain control and all the morbidity and problems that come with that. So when you look at these numbers, it gives you the assurance, or at least a partial assurance, that doing intrapleural fibrinolytic management is probably as efficacious as stats. Now, the problem is you need a protocol, you need IR support, and luckily at Mass General we have that. Actually, we now have a protocol, like a guide for these complicated perineumotic effusions. We have like a multidisciplinary team, ID, IR, and also surgery included with a primary team in that sort of multidisciplinary team approach, dealing with those. One last thing I probably should have noted in there is that there are now sort of reasonably or relatively recent guidelines from the IDSA about pediatric pneumonias and pediatric complicated pneumonias, the approach to diagnosis and approach to management from the IDSA website. And this is another thing or another piece of data you want to tuck away and refer to as needed. This concludes today my talk. I hope this was informative. Thank you very much.